So if I can go to the next slide, please. We just want to quickly let you know that the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services at SAMHSA or the U.S. Department of Health and Human Services. And importantly, we wish to thank the presenters for their time and effort for providing this educational experience. My name is Anna Zawislansky. I will be the facilitator for today's webinar. Please note that this webinar is being recorded, and all the participants' lines are muted except for the panelists and myself. Please note that at one point in the webinar, we will be pausing the slides and sharing with you a link to a video, a few-minute video for you to watch, and then we will resume the webinar after you are done watching the video. At the very end of the session, we will have an opportunity for you to pose questions to our panelists. We will do our best to answer as many of your questions as possible. We will remind you about this again at the end, but please use the Q&A feature in WebEx and direct your questions to Flo Pique-Monnier. And also at the very end of the webinar, you will be asked to complete a brief survey about the webinar. Please take a few minutes to respond to this survey. And one more thing, if you have any technical questions about the webinar, if you're having any problems with WebEx, please direct any questions to SAMHSA RM. Okay, let's get started. I want to briefly introduce our two panelists for today. Dr. Marvin Swartz is the Professor of Psychiatry and Behavioral Sciences at Duke University School of Medicine in Durham, North Carolina. Dr. Swartz served as a member of the MacArthur Foundation Research Network on Mandated Community Treatment and co-principal investigator with Jeffrey Swanson of the National Institutes of Health, National Institute of Mental Health study examining the effectiveness of assisted outpatient treatment, or AOT. Brian Stetton is Policy Director at the Treatment Advocacy Center in Arlington, Virginia. As an Assistant State Secretary General in New York, Mr. Stetton was instrumental in conceiving and drafting Kendra's Law, which you will hear about later in this presentation, the landmark legislation establishing AOT in New York. Mr. Stetton has worked with legislators and policymakers across the country to establish and improve AOT programs. We are delighted to have both here available to provide to us an overview of AOT and key issues related to clinical and legal matters. And with that, I will turn it over to Brian Stetton to provide an overview of AOT. Brian?
Yes, thank you, Anna, and good afternoon, everyone. Good morning to those of you on the West Coast. Really grateful that you've joined us for this important discussion. So let's jump right into it. Assisted outpatient treatment. Let me just think I have control of the slides now. And there we go. Okay. That worked. So assisted outpatient treatment is a legal mechanism specifically intended to address the challenge of treatment non-engagement. That is the reality that we have a small but persistent number of individuals in our communities with severe mental illness who have great difficulty staying consistently engaged in the community-based treatment that's made available to them, and who consequently cycle endlessly through these revolving doors, right, of the mental health system, racking up staggering numbers of hospitalizations over a period of years, and also in the criminal justice system, getting arrested and charged repeatedly for offenses that they clearly would not have committed had they been receiving treatment for their mental illness. Treatment non-engagement is far from the only challenge facing public mental health today, and solving it is not going to cure all that ails our public mental health systems. But I would submit that it's a problem that is exacerbating many of the other challenges we face, because the inability of this small group of folks to succeed with the resources that we do have available in our communities for them has really led to a disproportionate devotion of those resources to that subset, which of course leaves that much less for the many others who rely on public mental health systems to serve their needs. And as I say this, I want to be clear, I am by no means trying to blame the individuals who are stuck in this predicament. When we look at the causes of treatment non-engagement, we find there are a complex set of reasons why people have this difficulty. And with any individual who is stuck in this revolving door, you're likely to find unique combination of factors that explains it. And in this first slide, you know, we've ticked off some of the major barriers to treatment engagement, and we could no doubt fill up many more slides with this list. But in particular, I would like to focus your attention on the last item listed here, anosognosia, because it speaks directly to why there is a need for an involuntary remedy, which at the end of the day is what assisted outpatient treatment is, and because I think the research indicates it's an issue that we really have to get a handle on if we hope to make a significant dent in this problem. So, anosognosia. This is an inability of some people with severe mental illness to recognize that they, in fact, have an illness, no matter how painfully obvious it may be to everyone around that individual that they're in need of treatment. The person can't see it. And this is a symptom of brain dysfunction. It's estimated to be a factor in, you know, roughly half of people with schizophrenia, and it's often mistaken for denial. People will say, you know, my son is in denial about his mental illness. It's important for us to understand the distinction here. You know, denial is a universal human defense mechanism. It's something we all practice from time to time when there is some painful reality that you're unable to admit to yourself. But when you're in denial, you actually do know the truth deep down. You just may need some help coaxing that to the surface. A person with anosognosia, because of brain dysfunction, is certain to their core that they don't have an illness. The information simply isn't reaching them. And that's completely out of their control. It's no more their fault than any other dysfunction in any organ of our bodies would be our fault. And from that person's perspective, it actually makes disengagement from treatment perfectly logical. You know, why engage in something that's supposed to solve a problem that you are certain you don't have? And I think that's something really important to keep in mind is when we have a tendency to be frustrated with individuals who are in this situation. And, you know, as I say, it's one of many factors at play with non-engagement of treatment, but I think it is a big one, one we have to pay particular attention to, and this study I've cited here really speaks to that. This was published in 2006 in the journal Psychiatric Services, and I've got a citation at the bottom of the slide here. They looked at 300 individuals with severe mental illness, schizophrenia specifically, who had consistent non-engagement in treatment, and it was actually found that most of them did not have anosognosia. That only, in fact, about a third of the sample seemed to lack insight into their illness. But when those patients were tracked over time, that third of the sample correlated very significantly with the most severe problems resulting from non-engagement with treatment. So these were very much the individuals who had the longer periods of disengagement with treatment, who were more likely to completely stop taking their meds as opposed to tapering off, more likely to have severe symptoms, more likely to be hospitalized. On factor after factor, it was found that that third of the sample correlated with the most severe and tragic consequences of treatment non-engagement. And this really leads us, I think, into the rationale for assisted outpatient treatment, AOT, the idea that we need to overcome in some way the reality that some folks are simply not going to avail themselves of what's made available on a purely voluntary basis. So what is AOT? AOT is a clinical legal strategy. It's a collaboration, if you will, between the court and the clinical system, the treatment system, to intervene in the lives of folks who have this issue chronically. It is a form of civil commitment, short of hospitalization, right? We're familiar with the idea of civilly committing a person to inpatient care when they are in an acute psychiatric crisis. Here we are talking about a court order that comes into play when a person actually is able to live safely in the community, doesn't need to be in a hospital, but has demonstrated an inability to remain safely in the community because of a lack of engagement with treatment. And so we are putting this court order in place and at the same time placing the system under court order. It's very much about a mutual commitment, committing the system to the patient as much as we are the patient to the system. And this is not for everyone with severe mental illness. This is targeted to this very specific subset of folks that we're speaking of today. The specific legal process for AOT is hard to discuss in a national context because it's very much dependent on state laws. It differs very much from state to state. What we can say about this in a universal way is that it begins with a petition or an application that's made to the court, generally identifying a person as having a mental illness and having a need for outpatient treatment in the community to survive safely, and most critically, you're alleging in this petition that the person is unlikely to comply with that treatment on a purely voluntary basis. In many states, this is accompanied by the submission of a specific treatment plan that is tailored to meet the person's specific clinical needs, and this, of course, will all be backed up with medical testimony at a court hearing that takes place. Obviously, a person has due process rights before they are placed under such a court order, and so there is a need for medical testimony if the individual is contesting their qualification for this, that will speak to the criteria in that state, and also, if it's part of the process in that state, speak to the treatment that's been recommended in the proposed treatment plan. And if the court finds that the evidence supports these allegations made in the petition after the hearing, it will result in this court order that, as I say, puts in place this mutual commitment between the individual and the treatment system. So a couple other points I'd like to make before turning it over to Marvin. You know, you're going to hear us speak today about AOT programs, and if you look at your state AOT law, with the exception of New York, you're not going to find any mention of a program. You'll see the description of a legal mechanism that is available in a specific situation where a person meets certain criteria. But what we're talking about when we speak of AOT programs is simply the idea of a community mental health system in collaboration with the court that has jurisdiction over this type of case, coming together to identify all folks who meet these criteria, right, to actually rescue people from this revolving door by saying in a systemic way, we're going to identify all the folks who meet these criteria. We are going to bring petitions to bring them into this program. Once they are in this program, we are going to commit ourselves as a system and as a court to delivering treatment services, intensive case management, which generally is going to be necessary to help these folks survive safely. We are going to take swift action when it becomes apparent that a person is disengaged with treatment, and we are going to figure out how long to keep these individuals under these court order. Again, in a systemic way, you have to do this on a case-by-case basis, make a determination at the end of the court-ordered period whether it's necessary to renew or whether this is an individual who's ready to, quote-unquote, graduate from this program. An important distinction to make is that this is not mental health court. It's a similar concept that I think has taken hold much more commonly in American communities, and so there's often a sense that if we have a mental health court, there is not a need to do AOT. Very quickly, the essential difference is that a mental health court is for people who are already in the clutches of the criminal justice system. So what's happening there is that we're saying that this criminal charge you're facing, we think you don't need to be punished for it because you're actually in need of treatment much more than punishment, and so we will put this to the side and give you a chance to complete a treatment program and then have that charge go away, which is a wonderful thing. Every community should have it, but it's not in itself enough, because we should not have to require the commission of a crime to get somebody the help they need. This is a purely civil procedure. It's not predicated on the commission of a crime. And there are some other differences that I'm going to gloss over at this point in the interest of time. I do want to just say a little bit about the court order itself, because it's important to understand that this is not like other court orders we talk about in the law. This is not punitive in any sense, right? There is, in many states, it's actually explicitly stated that you cannot hold someone in contempt of court for violating this court order. We don't want any punishment attached to it. We don't want people in these programs to have the sense that they are in trouble. We are not trying to create a new pathway into jail for people who are found in contempt of court. We're not going to forcibly administer meds as a direct consequence of not following this court order. And so, you know, it's fair to ask the question, well, what is the point if this court order is on the surface fairly toothless? The point, I think, will become clearer as we discuss this further today, but in a nutshell, we are trying to motivate and inspire people and get their attention simply by involving a court. We are trying to leverage the fact that people take what is said to them by a judge seriously in a way that you don't necessarily take it when it's said to you by your doctor or your mother. The ritual of the court process is something we are trying to use to the advantage of the individual and keep them on a safe track through that type of intervention. And of course, we're also facilitating a response to non-compliance with treatment that would not otherwise be possible. Again, we'll get into that further. But at this point, I'd like to turn it over to Dr. Swartz.
Well, thanks very much, Brian. I am a clinician, and I've been a psychiatrist, and I've worked in a number of settings, and have been interested in trying to understand whether AOT works and for whom it works. And recently I had the opportunity to work with the American Psychiatric Association to try to summarize how to think about AOT. And so I'll start off, before I talk about the evidence, talking about what the APA, the American Psychiatric Association summary, is about assisted outpatient treatment, also called involuntary outpatient commitment. And this is what the APA says, that AOT, if systematically implemented and resourced, can be a useful tool to promote recovery through a program of intensive outpatient services designed to improve treatment adherence, reduce relapse and rehospitalization, and decrease the likelihood of dangerous behavior or severe deterioration among a subpopulation of patients with severe mental illness. The goal of assisted outpatient treatment is to mobilize appropriate treatment resources, enhance their effectiveness, and improve an individual's participation in the treatment plan. And we note here that AOT should not be considered as a primary tool to prevent acts of violence or to move to the front of the line in areas of treatment scarcity. So the American Psychiatric Association really wanted to say that it's important to recognize that AOT works by mobilizing resources, by setting up a plan between the court, the family, the patient, and providers to achieve the goal of treatment adherence, and that how the program is implemented and the attachment of intensive resources over a period of time is critical to the success. So we like to say that the question isn't whether AOT is effective, it's really under what conditions and for whom AOT can be effective. So we also went further in the APA position statement to show that studies have shown that AOT is most effective when it includes a range of medication management and psychosocial services which are equivalent in intensity to those provided in assertive community treatment or intensive case management. But this does create a challenge for states because in adopting these statutes and setting up these programs, they have to assure that there are adequate resources to provide the types of intensive services that are needed. And we've shown in studies that when it works through the collaboration with the court and the application of intensive treatment resources. We also want to be clear that this shouldn't deprive others in similar need who've not been placed under AOT, so that while the AOT programs are important, we also want to assure that people not under court order have good access to services. So we did a study in 2005 as part of the MacArthur Research Network trying to see how often AOT was being used. And in 5 cities across the country, we found that about 12 to 20% of a 5-site sample of outpatients in public systems of care reported some type of involuntary outpatient treatment. But, and this is important, that there were a number of different types of leverage that were applied to folks with severe mental illness. And it wasn't only AOT. There were also other types of leverages applied through the criminal justice system or the social welfare system or in housing systems, and so that people with severe mental illness actually may encounter a number of different types of attempts to engage them in treatment and to improve adherence, and that AOT is not the sole mechanism that treatment systems and agencies are using to try to enhance treatment adherence. Meldrum did a recent survey of AOT implementation, and what their group from Washington did was try to look across states and look at how AOT programs were operating. And this is basically a survey of state stakeholders trying to understand how AOT programs were being implemented. And their not surprising conclusion is that when you've seen one AOT program, you've likely seen one AOT program, in that they vary considerably in terms of how they're implemented, what the statutory criteria are and how they're applied, as Brian mentioned, which agency is responsible for taking the lead for the AOT program. It might be the mental health agency, it might be a different agency. How they use treatment plans and how prescriptive the treatment plans are. In North Carolina, where I live, the treatment plan is not specified in the court order alone. It only says that you will comply with the treatment plan and then the treatment plan is developed. Whereas in New York, for example, the treatment plan is written into the part of the court order process. These programs also vary on how monitoring is done, how we would keep track of folks under AOT, and how many participants are in a given program. They noted that there really were three different types of implementation models. One was what they call the community gateway, and in this instance, the AOT program was used as a method, and these are not mutually exclusive implementation models, but in this case, the community gateway approach was using the AOT program as a method to assure access to community services. The second, and I would say probably the most common model, is hospital transition. And this is using AOT as a step down from inpatient hospitalization. And in our study of New York AOT, we found that 80% of people in the AOT program in New York started from an involuntary hospitalization and stepped down to the AOT program. So this is probably the most common model. And then as a surveillance model, as a method to assure persons don't fall through the cracks. Now these different models are really matters of emphasis in their models and not mutually exclusive. They noted that in AOT implementation there were some common problems. One was that some of the AOT programs had inadequate resources to really carry out a robust program. So for example, they may not have the types of ACT services or intensive case management services that are really needed to make the program effective. Some programs lacked enforcement power, and there was lack of clarity about what happens in the absence of treatment adherence. In North Carolina, what the statute says is should a patient be non-adherent, the person will be picked up by law enforcement for hopeful persuasion to accept treatment. So essentially the enforcement power in North Carolina is the, quote, pickup order, law enforcement transporting the patient for this hopeful persuasion and reevaluation. There are common problems with inconsistent monitoring. How are folks under court order monitored and their progress monitored, and the need for the order and whether the providers are complying with the order? All those things are inconsistent across the programs. And one of the things they noted, which I think was an astute observation, is that in some programs the agencies that are involved with the patient aren't collaborating optimally. So there is uneven implementation of AOT programs both within and across states, and their observation was that there was ambivalence in the community among judicial officials and mental health clinicians about the role and scope of AOT, and the difficulties of implementation existed under existing funding constraints and statutory limitations. And I think this is an important point because in the work we've done at Duke, we have found that programs are effective because there is a collaboration between the court, between the providers, and between the patients and families about trying to achieve this objective of enhanced treatment adherence and improved outcomes. Now, what's the state of the evidence about AOT? And there's quite a bit of controversy about this, and I will just summarize it in the following way. I think we originally asked the question, well, is AOT effective? And we've now changed our thinking about the question so that we ask, can AOT be effective under what conditions? Because that previous question of is it effective really thinks about AOT as if it was a drug. And like drug A is better than drug B, is it superior in a clinical trial? But so critical to AOT success is how it's implemented and how it's applied. There have, however, been randomized trials of AOT. There was the Bellevue study that was during the pilot phase of Kendra's Law, or the AOT program in New York, which found in a very small scale study that there was no benefit to the AOT program in its pilot phase. We did the first randomized trial of outpatient commitment in North Carolina, and we did find that people who were under the AOT program as conceptualized in North Carolina were less likely to be rehospitalized if you looked at their progress from month to month, that they had fewer hospitalizations, and if the order was applied over a period of 6 months or more, that they were less likely to be victimized, to be violent, got along better with their families, were more adherent with treatment, and had improved subjective quality of life. The third randomized trial was the UK study, which I think was not really comparable, but it found under a new law in Great Britain that their form of outpatient commitment, or AOT, provided no benefit. I would say that the largest study of AOT was of the best implemented and best conceptualized study program, and that's the AOT program in New York, and I'll say a little bit about that in a moment. The evidence reviews, the large reviews of sort of synthetic analyses of AOT programs, usually only look at randomized trials. And as a result of only looking at randomized trials and not, for example, our quasi-experimental evaluation of AOT studies looking at the entire population of people under AOT in New York, these very selected systematic reviews of these randomized trials only look at randomized trials, and they inevitably will conclude, because they're only looking at a segment of the literature, that AOT is not effective. So the big picture, and what we concluded with the American Psychiatric Association, is the evidence for AOT is somewhat mixed, with success largely conditioned on the investment in effective implementation, the availability of intensive community-based services, and the duration of the court order. We found that a court order of 6 months or more really enhances the effectiveness of AOT. Now, not everyone agrees with us, and this summary, which the American Psychiatric Association also endorsed, is not shared by all the stakeholders who may be very critical of AOT. Now, let me just briefly talk about this study of New York system, which is the best implemented and most comprehensive program in the country. And we studied all the people under AOT during the first period of the AOT implementation from 1999 to 2000. And we looked at people pre and post AOT compared with a comparison group who did not have AOT. So we looked at roughly 4,000 participants on the AOT program, looking at a number of outcomes such as hospital use, medications, receipt of services, so on and so forth. One thing we found, which I think is a really critical thing to recognize, is that AOT did exert a beneficial effect in terms of outcomes over and above the effect of assertive community treatment or intensive case management. Many critics of AOT say, well, if you just provided intensive community services, people would not need AOT. But in this study that we show you in this slide, we found that even if you were receiving ACT alone or intensive case management, the addition of the AOT order enhanced the outcome, and the monthly probability of hospitalization was reduced by roughly 50% for participants who were already receiving ACT or ICM, but in addition received AOT. So there was an incremental benefit of AOT over and above the effect of ACT. The other important thing I think that we reported, and this was reported in 2013 in the American Journal of Psychiatry, was that AOT did reduce total cost. And in this slide, you see in the red circle that over the years pre and post AOT, for people who were either about to get AOT or got AOT, that their outpatient mental health treatment costs went up, as expected. You would expect that people under AOT would incur more expenses in terms of outpatient mental health services. And you see there that roughly their outpatient mental health treatment costs went up maybe 3 times. However, the savings, you will see in a moment, were in hospitalization. And so if you looked at the hospitalization costs either at the state hospital or in hospitals billing Medicaid, so the non-state hospital system, that the hospital costs went down significantly. And so you see hospitalization in state hospital or hospitalization in non-state hospitals. And you see from a cost of about $50,000 either in one of each of those types of hospitals, or actually in aggregate $100,000, the cost went way down to about $11,000 or $22,000 in non-state hospitals. In aggregate, what this showed was that total costs for recipients under the AOT system were roughly cut in half in the first year of their participation, and then stayed about 50% lower in their second year. So despite the increase in their outpatient mental health treatment costs, their costs of hospitalization and thus total costs were reduced significantly. Over the years, when we've studied AOT, we've also asked, well, what do people who are participants in the program think of AOT? And when we surveyed people in North Carolina who were under AOT, they reported that their subjective quality of life was better under AOT. So they reported that they were doing better, and their total quality of life was better under AOT. However, when we asked them, do you think you actually benefited? They thought their life was better off, but did you need AOT? Would you want to do it again? A minority of people reported that they personally benefited from AOT. And this could be consistent with Brian's observation that if you have a lack of insight, if you don't recognize your role, you don't see necessarily endorse the benefit of this program. And this goes back to a concept of thank you theory. This was a theory that was originally written about by a Professor Alan Stone, who said one way to evaluate these programs is to see retrospectively whether people say, thanks, I needed that. Well, in fact, when we looked at it, we found that by and large, only a minority of people under AOT thought, thanks, I needed that. Although if they did do better, if they actually were less likely to be hospitalized and had better outcomes, they were more likely to endorse this benefit. But in some ways, I think the most important outcome that we found in this study was when we asked people what they thought of AOT and what they thought of being under a court order. Largely people with severe mental illness said that, you know, the court order really doesn't bother me that much if I receive the benefits of it, so that if I'm less likely to be in the hospital, if I'm less likely to be victimized, if I'm more likely to get along better with my family, then I'm willing to trade off the court order and the whatever hassle there is to the court order to receive those benefits. And we found that 4 stakeholder groups, patients, their families, clinicians, and members of the general public all said we would be willing to trade off, in effect, our civil liberties if we could receive the benefits of AOT. So just to summarize this part of the evidence and return it back to Brian, Robert Miller, now 30 years ago, who was a scholar of AOT, said, we need 3 things for AOT to succeed. We need empirical, rigorous research to examine its effectiveness. We need support from community-based clinicians, and we need sufficient resources to permit adequate treatment to be provided. And I think what we're seeing now is that some of these things are coalescing and coming together, both research that elucidates how AOT can and will work. We're getting more support from community clinicians, and we're also seeing that adequate treatment is starting to be provided to these treatment programs. So let me turn it back over to Brian.
Thank you, Marvin. And Anna, at this point, we're going to provide the link and let people watch a short piece of video to see AOT in action, which I think will inform the rest of our discussion.
Yep, that's exactly right. We are right now chatting the link to everybody, to all participants. Please copy the link and paste it into a new browser window to watch the video. It's just, it's very brief, and we will resume the webinar in 2 minutes.
Very good. Donna, could you let me know when it's time to resume?
Will do. I think we're having some technical difficulties with sending that link.
Yeah, so I didn't get the chat link.
If you could, if folks can please just use just type in the URL that's on their screen. Okay, Brian, I think we can resume.
Okay. Well, I hope everyone was able to watch that. Sorry if we had any technical problems that made it impossible for anyone. But for those of you who did see the video, you know, I think it's worth, first of all, making clear there may be some apparent inconsistency in what you've seen there, because we've described this process as involuntary and as something that is used for individuals who don't want to engage in treatment. And actually what you saw there was somebody who's about to be discharged from a hospital who's actually welcoming and embracing becoming part of this program, and it all looks kind of like a feel-good situation. And I can tell you from my observation of lots of effective AOT programs around the country, that actually is the norm. It is most typically used upon discharge from a hospital when a person has been hopefully stabilized to the point where they're now ready to come back into the community. And at that moment, you often do have individuals, I think more often than not, who are entering this program happily, and there is not generally a need for a contested hearing with a presentation of evidence in a formal way, but rather people are often signing voluntary settlement agreements, as this individual did, and embracing the program from the beginning. And that may raise a question in your mind, well, why does this need to be court-ordered? Why make this involuntary? And what I ask you to keep in mind is, and this is going to be something very well known to those of you who work in the mental health field, this grasp on insight often is very tenuous. I don't mean to suggest when I talk about anosognosia that it's always a fixed situation where the person has no idea at any time that they have a need for treatment. For many folks, this is something that comes and goes. So it's not unusual to see somebody coming out of the hospital with the best of intentions to engage in treatment, and very grateful to be placed in a program like this. The reason we want to make it court-ordered is because we're applying this to folks who've given their history, give us reason to think that they're not going to be able to hang on to that perspective, that in 2 or 3 weeks' time they will start to tell themselves, as they're feeling good, that maybe they don't really need these meds, and then start to go off them and disengage with other forms of treatment as well. So this is really about getting in front of that pattern, and again, it's not meant to be applied generally to people who have not given us reason to think that that's what's coming down the pike. So with that said, let's talk a little bit more about state AOT laws and their variations. There are elements that really do change quite a bit when you look from one state to another. The particular criteria under which AOT can be imposed is a major difference in what you see from one state law to the next. States also vary in terms of who they allow to bring these petitions to court. It's always possible to bring it as a mental health system, or as a hospital about to release somebody, or as a psychiatrist treating the person in the hospital. But other states open the process up to family members, law enforcement individuals, and sometimes even to any person who's able to come into court with sufficient evidence. There is variation in terms of how involved the court is in the specifics of the treatment. Some states require the court to review the specific treatment plan. As Marvin said, there are other places where the court is simply saying, you are hereby released to the treatment that is provided for you by X provider, and we'll leave it to them to say what that's going to be. The role of the court is also something you see some variation in, how much the court is actually staying involved over the period of the order. In my view, the best AOT programs are the ones that hold periodic status conferences that actually check in on people and reinforce that sense that there is a court paying attention to the treatment and giving people lots of positive reinforcement when, as in the typical case, they're doing well. And the maximum length of the court order is something that varies quite a bit. There are states that limit it to as little as 90 days. Others, could be as much as a year. I think that some of Marvin's research leads me to believe that 6 months at a minimum is what's needed for these habits of treatment adherence and treatment engagement to take hold. And so I think we have reason to think that shorter periods of treatment should be renewed. So if you have a state where you're only putting someone under AOT for 90 days, research indicates that it would be advisable in most situations to renew that for a longer period. But again, this is a clinical determination and has to be made case by case, and you have to be able to reestablish that the person continues to meet the criteria. I am going to skip over a couple of these slides because I know we want to leave time for questions, so I apologize for that. But I do want to talk a little bit about some of the case law we have on AOT. There has only been one case where this concept has been challenged as unconstitutional, and that was in New York shortly after we passed Kendra's law. And the argument that was made there by the New York Civil Liberties Union and some other groups was that this was a form of forcible medication, and that in fact there is lots of precedent under both the New York Constitution and other states as well as the federal Constitution that you cannot forcibly medicate an individual without first finding that the person lacks capacity to make their own treatment decisions. And the argument, therefore, was that because Kendra's law did not involve a finding that the person lacks capacity to make treatment decisions, of course, that is by design, since, you know, as we've discussed, we want this to apply to people who are actually doing pretty well at the moment they come into court. The argument was that because this was not part of what was used to impose AOT, that it violated the person's rights to not be forcibly medicated. And the Court of Appeals of New York, which is the highest court in that state, one known as a stalwart defender of civil rights and individual rights, unanimously rejected that argument, basically finding that AOT is not a form of forced treatment. The exact words of the court were that the restriction on a patient's freedom affected by a court order authorizing AOT is minimal inasmuch as the coercive force of the order lies solely in the compulsion generally felt by law-abiding citizens to comply with court directives. And this is sort of a fancy way of the court saying that there's no force involved here because there was no punishment attached to violating the order, that in fact the law was relying on the tendency of people to want to do what a court has asked them to do and to take seriously the fact they've been placed under court order, and to keep in mind that they are going to have to come back before the court and discuss how things have been going. That's all that this concept is relying on at the end of the day. That, and of course the equally importantly, the caring involvement of a high-quality treatment team. And so the court didn't see any force there and was untroubled by this on a constitutional level. How to get an AOT program off the ground in your community is something, again, I wish we had more time to talk about it. I encourage anyone listening to this to please get in touch with me and my organization, because it's something that we really enjoy and have a lot of expertise in working with communities to do. But to summarize very quickly, it's a process that has to begin with all the stakeholders buying into the idea that this is something that you want to do and want to do right and do effectively, because as Marvin points out, all AOT programs are not created equal. The places where this has been found to be effective are where it's been done right and where all the T's have been crossed. So to do that, it's really going to involve a coming together of your public mental health agency, your court that has jurisdiction over this type of case, your psychiatric hospitals in your community-based providers who are going to be involved in helping people once they're under court orders, the attorneys who represent each side in civil commitments in your state, and any local groups that represent people with mental illness and their families, such as NAMI. All really have to be brought together, I think, at the beginning to have a good chance of successful AOT implementation. And once there is this mutual understanding, this is something we want to do, you've got to design a process which involves actually mapping out who's going to identify the folks in need of AOT, who's going to bring the petitions, who will develop the treatment plans, et cetera. The very specific mapping, I think, is something that should take place before you even attempt to get this off the ground and have really a full understanding among everyone as to what the individual roles are in making this work. And then, of course, there are likely to be questions to answer as to how it's going to be funded, because there's no getting around the fact that this does involve an initial investment. I think Marvin's evidence is very compelling that ultimately this is a money saver, and that the fact that you may have scarce resources and are financially challenged in your community is actually an important reason to do this rather than an excuse not to. But there is undoubtedly a need to marshal resources to make that upfront investment. And, this, if it can't be addressed through some kind of a specific funding source that's bringing in new money, if it has to be done through allocating existing resources, it's going to take a realization on the part of those who are currently paying for the cost of treating people in what I would argue is a much less efficient way, which mostly takes the form of repeated hospitalizations, realizing that those resources could be more efficiently allocated so that you could treat people in a community setting such that you would save quite a bit on hospital costs, and there's an opportunity there to redirect resources. Similarly for the courts, who are currently doing lots and lots of inpatient commitment hearings for people, the resources that are currently devoted to that can, I think, be reallocated with great effect towards doing more of a check-in on folks on an outpatient basis, holding AOT hearings up front, and then realizing savings by not having to do as many inpatient hearings for the same individuals coming back to the hospital again and again. So these challenges are all surmountable. We've seen it happen in many places. I encourage anyone to get in touch with the Treatment Advocacy Center to talk more specifics about how to make that happen for you. And
Great.
with that, I think we'll move to Q&A.
That sounds great. Thank you so much. This has been fascinating. We've gotten lots of great questions coming in, and if folks have more questions, please submit them to Flo Pique-Monnier, and she will put them into the queue. And I apologize in advance. We probably will not be able to get to all the questions, but we will do our best, and I think we can go over a few minutes if participants are willing to stay a little bit longer.
Happy to.
Thank you. So the first question I want to pose to the panelists that has come in from Denise Piper. Dr. Swartz is talked about involuntary AOT. Can AOT be voluntary, as Brian said, to inspire and motivate?
Yeah, I'm happy to take that. So the answer, and I appreciate the question because I know it's a point of confusion when we try and address this subject as briefly as we have today. For most people who enter these programs, in fact, it is voluntary, much like what you saw in the video, where you have someone who sees this as a route out of the hospital and is typically embracing being placed in a program such as this. And so it's common to enter people into AOT under voluntary settlement agreements and to have more of an informal court hearing rather than a formal one, such as what you saw, with everyone seated around the table in the video. But I think it's important to keep in mind that when the opportunity is presented to people to come be a part of this program and do it voluntarily, there should be an understanding that if the person declines, that it will result in the filing of a petition. And so one way or another, we have, as a system, made a determination that this is a program a person needs to be a part of. And although it's obviously always best to have that buy-in up front and do it voluntarily, if that isn't going to happen, we're going to place this person in AOT anyway. And that's, I think, an important difference from mental health court, right, where it really is a voluntary choice. A person who is asked to or given an opportunity to join a mental health court can say, well, no thanks, I'd rather roll the dice, face my criminal charges, and see if I can, beat the rap and not have to do any treatment at all. That's not an option that should be on the table with AOT.
Great, thank you so much. There are two questions that came in that are sort of similar, so I'm going to combine them. One came in from Sherry White and one from Nora King. They're asking about whether there are particular programs in California, and also if states that do have AOT, are the programs statewide, or can they only be available in certain parts of the state?
You want to address that, Marvin? I'm happy to, if not.
Sure. So California is a bit of an anomaly because when Laura's Law was passed in California, the legislature had a proviso that each county had to determine whether it was going to set up an AOT program or not. And so you'd have to go to those counties to see which counties have done that. There's a number of counties in California that have. But this is a distinction that Brian was making before, is there's a statute, and then whether it's implemented and how it's implemented varies from state to state. The SAMHSA grants to programs were largely local, not statewide. So whether a state has goes through and implements the program statewide is really a state determination, and depends on what that state is going to do. And that was why we went through these varieties of implementation, because there are a lot of differences across states.
Great, thank you so much. Another question that we got was from Beth Mitchell, and she asks, doesn't having police involved increase the likelihood of criminal involvement?
I would submit not. You know, typically when police are involved, certainly as a best practice, it's officers who are CIT trained, that is officers who have a particular specialty in dealing with mental illness in the community based on the training that they've had. And, you know, if you look at the way CIT officers typically engage with folks in the community, it's very much in a non-confrontational, non-threatening, supportive manner. And, you know, that's certainly the way any law enforcement involvement with AOT should be conducted. And so, you know, when you know, police officers who are CIT trained are not necessarily looking to arrest folks. What they're trained to do is look for alternatives to arrest, opportunities to engage people in treatment instead. And so to have a police officer on a CIT beat in a community who is aware that somebody who he's observing acting out in a certain way is under AOT, or might be a good candidate for AOT, actually creates opportunities to avoid arresting that individual and charging them with crimes, because, you know, I think police departments have generally recognized that's the last thing they want to do. I don't mean to be Pollyannish about it. I understand that there are places where that is not actually happening, where that's more theory than reality. But I can tell you that when my organization works with communities to implement AOT programs, that certainly is the model we're looking for them to follow, and certainly the way that we think it ought to be done.
Excellent, thank you so much. We have a question from Amanda Rosen that is, do the current AOT programs provide housing to their clients in addition to mental health services?
Marvin, do you want to try that?
So there's a lot of variability there as well, but I'd say some of the model AOT programs like New York's does, as part of the treatment plan, try to make sure that people get into housing that's appropriate for their needs. And so in New York, you see that the folks who need housing in the AOT program do get priority, and the program works with the available programs to make that happen. Because by and large, you know, the housing is not a part of the mental health system, it really requires some collaboration between the folks who are trying to implement the plan and housing providers. So it's not automatically a part of the program unless there's a specific mental health related housing provider, but usually that coordination is very important to the success of a program.
Yeah, obviously, you know, the more supportive services in a community you can link AOT to, that is the substance of what you're court ordering a person to participate in, the more robust you can offer, the more likely you are to have success with this particular approach. And so, you know, I would not go so far as to say that there is no point in using AOT in places that don't have housing services available. You know, there might be a need in certain places to limit the scope of who you can actually help with programs like this, because, you know, you might have to limit it to folks who actually do have a place to live. But to the extent you can attach supportive housing to an AOT court order, it's all to the better, and it's only going to make your program that much more effective. You know, AOT cannot be thought of as something that's going to solve the fact that we have shortages of critical resources all over this country. You know, those are problems that are going to have to be solved independently. And as they are solved, as we do get more resources into our community-based mental health systems, AOT becomes that much more effective a tool.
What we did find, this is Marvin again, what we did find in New York when we did our interviews with people in New York is that housing providers in many cases preferred AOT recipients because they knew they had a program around them and that there were treatment resources involved in their care. So it clearly does facilitate access to housing when the program's well implemented.
Great, thank you so much. We have one question from Maria Grahams. How does this compare to guardianship or conservatorship?
Well, a guardianship, you know, again, that's kind of an answer that varies by state because guardianships look different in different states. But to give you a very general answer, a guardianship is a legal mechanism that comes into play at a point when a person is unable to make their own treatment decisions. So where it might become necessary for someone who is hospitalized to forcibly medicate that individual as a last resort because they can't be made to understand their own need for medication. The guardianship law is there for that guardian to step in and make a surrogate decision. AOT is not about what we do with the individual who is in crisis who needs to have a surrogate decision made. It's about keeping a person from reaching that point in the first place. So it's about making treatment decisions, hopefully as collaboratively as possible with the individual involved in the development of that treatment plan, to where you will hopefully avoid a person reaching a situation where they are in psychiatric crisis and need to have a guardian make an immediate treatment decision. So, you know, in that way, I think the two programs and two approaches can coexist, and, you know, AOT is a means of making the need for guardian less acute, yeah, that's about how I'd put it.
Great, thank you so much. We've gotten several questions from Amber Decker. One question is, what can an individual do when the consumer meets the criteria for ACT, which is an alternative to AOT in New York State, but is placed on a waiting list?
Well, I don't necessarily agree that ACT is an alternative to AOT. I think there are lots of folks in New York and elsewhere who have been placed in ACT under AOT court order. That is, the specific treatment they are court ordered to participate in is working with an ACT team. So I don't know if you want to add anything to that, Marvin, but I'm not sure I fully understood the question, but I don't really see the two as alternatives.
No, and what we've, you know, what I presented before was that there was additional benefit of AOT over and above the effective act of assertive community treatment.
Okay, and we have, I think, time for just maybe two more questions. One that came in from Nat Nguyen. Interesting that the recommendation is 6 months, but our AOT program is only for 90 days. Is there a way we can convince the judges and legal system to base their duration on this recommendation?
Well, again, you keep in mind that although I'm not sure what state that question is coming from, but if your law is limiting the court order itself to 90 days, I don't believe any state at this point that is saying that 90 days is the end of it. There's always that opportunity to come back to court and potentially renew the court order if the person continues to meet criteria. And so I would encourage anyone operating an AOT program in a state that limits the period of the order to 90 days to generally think in terms of renewing in most cases. But again, that has to be made case by case, a clinical determination of what that particular person needs. There may actually be individuals for whom you find 90 days is enough. But I would imagine that should be the exception rather than the rule, and you should not think in terms of the period of the order being the end of any opportunity to offer AOT, because there is always that renewal option.
Thank you so much. We got two same questions, one from Lori Berry and one from Clarice Hamblin. Can you speak to modifying an AOT order to improve compliance and monitoring?
Sure. So modification of the order is the process that most state laws establish for, what to do when the court order as originally imposed is just not working. It generally under state laws, you have an opportunity to come back to court, have the person reevaluated, and present evidence that there is a need to either modify the order into an inpatient court order, that is a finding that this person is just not succeeding in outpatient care and needs to be in a hospital because they now meet inpatient criteria, or alternatively change the terms of the order to make it more aligned with the person's actual needs to survive safely in the community. And that's a process that could be initiated either by the individual under AOT if they are, just not connecting with their treatment team in a way that they can make the treatment team on its own understand that there's a need to modify the order and the person wants to see the judge. Generally, state laws allow the person to come into court and make the argument to the judge that the treatment plan as currently constituted does not represent the least restrictive appropriate treatment. And more typically, it's going to be the treatment team itself that initiates that need to modify the order based on their own findings that the person just isn't doing as well as they might. But again, it's kind of a hard thing to give you a lot of specifics on because the process is going to depend on your state law, and I encourage you to get in touch with me after the webinar.
Thank you so much. Okay, I do have one more question. We got several questions around this, so I'd like to end the webinar with this question. Do you know of any studies around using AOT with substance use disorder? How can AOT model be applied to, for example, opioid use disorder? So I wanted to, I think that's an important and timely question. So let me end the Q&A session with that final question for the panelists.
So I'll take a stab at it. And there's quite a lot of discussion about use of involuntary commitment with substance use disorders. And there's a lot of variability across states and whether they even have such a statute. I will say that we did, in our study in North Carolina, look at people with dual disorders, so people with comorbidities of severe mental illness and a substance use disorder. And we found that those folks actually benefited despite some skepticism that they would. These were folks who were, very likely to be rehospitalized, were pretty unstable because of the dual disorder. And so those folks did benefit, but whether it would, you'd see the same benefits from opioid disorders where you didn't have severe mental illness, I think that's a great question worth exploring.
Great. Thank you, everyone, very much for participating and for submitting your questions. Our apologies for not being able to get to all your questions. We want to remind you that this webinar was recorded, and it will be, once it's captioned, it'll be posted on SAMHSA's website with the audio. We will be sending this slide presentation to all the participants shortly, so you'll receive that with the email that you used to sign into the webinar. We want to thank Brian Stetton and Marvin Swartz for their time. We really appreciate their involvement and the great presentations that they gave today. Their email addresses are provided on this closing slide. If you'd like to ask them any questions, please do so. On behalf of SAMHSA, thank you for participating in today's webinar, and have a good rest of the afternoon.
Thank you.
Thank you all.
Thanks. Bye-bye.
Bye-bye.